time. Welcome to HFMA Colorado Chapter webinar series. We want to take a moment first to recognize our annual business partners who not only provide financial support to our chapter, but also share their knowledge and their expertise in webinars just like these. Without them and their support, our chapter would not be able to run successfully or provide the kind of education you guys look for and rely on from HFMA Colorado. So we hope that if you are ever in need of services, you will take a look at our sponsors first. A reminder that certification is now in part of the HFMA all-inclusive membership. So if you've ever considered getting certified before, make sure to reach out to your chapter. Talk to us. We'd be happy to get you on the road to certification. For today's webinar, we will be using the chat box located on the bottom right hand of your screen. And we will address questions as we go, as we can, and we'll address any of the remaining questions at the end. A link to download the presentation will be made available in that chat box, as well as sent to you at the conclusion of the webinar, along with a recording of today's webinar. So look for that probably around Friday is when I'll be able to get all of that out to everyone. Also look for the survey because your feedback is absolutely invaluable to us as a chapter in future planning. Today's webinar, Value-Based Contracting, a collaboration of providers, finance, contracting, RCM, IT, clinical, and compliance resources, is being provided by one of our gold sponsors, Plant Moran. It is my pleasure to introduce you to our speakers. Sue Marr is a principal, healthcare management consulting at Plant Moran. Sue focuses on acute providers to improve their financial health through revenue growth and driving operational performance, or operational excellence, pardon me. Sue has been delivering value-based strategic consulting services to improve quality outcomes and navigation from fee-for-service contracts to two-sided risk options. She brings understanding of revenue cycle management and reimbursement, experience of strategic planning and execution with significant growth and actionable data analytic insights. Dr. Heidi Steiner is a senior manager in the healthcare management consulting with Plant Moran. As a doctoral prepared board certified informatics leader, Heidi brings 27 years of diverse healthcare experience to Plant Moran. As an informatics expert, Heidi analyzes healthcare's changing needs and advises executive leadership and clinical teams to solve complex healthcare problems. With over 15 years, specifically of informatics experience, Heidi has seen the industry from multiple angles: a vendor, a consultant, an informatics leader in large, complex healthcare organizations. Heidi specializes in aligning healthcare technology to organizational strategy, then collaborates with those clinical teams to simplify workflows and optimize technology to improve the patient experience and provider efficiency. Using evidence-based approaches, Heidi excels at streamlining and standardizing people, processes, and technology to help clients reduce readmissions, improve HCAP scores, and reduce lengths of stay. Please join me in welcoming Ms. Marr and Dr. Steiner.
Thank you, Jessica.
Thank you, Jessica. We're very excited to present today to the Colorado chapter. Hopefully everybody can see my screen.
Not yet.
Not yet, Sue.
All right, let's try this again. How's this?
Very good. All right. Yes. Thank you, Jessica, for that intro, and welcome to today's session. Our learning objectives for today is that by the end of our session, we would like you to know the value-based contract models, including Medicare Advantage, Medicaid replacements, commercial payment models, and direct contracting. And Sue's going to do a great job of helping you understand the spectrum of risk sharing arrangements, including upside risk only, two-sided risk, capped risks, PCP versus specialty-based, HCC, RAF versus cost only and quality incentives. And we'll also would like you to understand the resources needed to coordinate a successful shift from fee-for-service to value while maintaining the fee-for-service operating margin. And then we would like to make sure that you can describe the relationship between quality improvement and the goals of managed care contracts to control costs and improve quality of care, and describe how innovation is impacting value-based care. So with that, I'll turn it over to Sue to get us started.
Sure. There'll be 3 polling questions throughout the presentation for CPE purposes. And the first one, let's start. What is value-based contracting? Is it pay for performance? Bundle payments for care, risk-based contracting, Medicare Advantage plans, or Medicaid replacement plans? Jessica, would you be able to cue us when the results are in?
Sure. We're at about 8 of 22 participants so far.
Okay, majority of you said that it means pay for performance, and then 33% says bundle payments for care. Some says risk-based contracting. 0% picked Medicare Advantage plan and Medicaid, but we can talk about that in terms of how this all ties together. Okay. So first question is, many people say, what value-based contract, how many models are there? Every time seems, every month you hear something new. Matter of fact, depends on who you talk to, what part of the country they're in, what type of specialty they're in. They could be talking about many, many different things. In the last 10 years, CMMI came up with 54 different models. The models all have lots of pros and cons. Some people really like a certain model. Some really have strong opinions about it. For example, the pay for performance model, one of the biggest objection is that it lacks incentives to change physician behaviors because it does not involve financial risks. So again, the point is there's a lot of models. Majority of them have not been super effective in saving money, which is, of course, was one of the very first goal. But similarly, we have seen improve in care, quality, etc. So the point is, based on the models you have contracted, it really makes a difference of what resources you need, how to calculate criteria that you're being measured on, how are you getting reimbursed, etc. So need to be super familiar with the specific models you're contracting or consider contracting with. Okay. Next couple of slides, it looks super busy, and that's by design. There's a lot of new models with increased risk that's coming up into the market, right? ACOs with the different types. You see the track 1, track 2, track 3, the next gen ACO model, Pioneer model, and now the direct contracting model is totally the hot topic, whether or not it's professionally based, global, or geographic. They also opened up these things called primary care first value-based payment model. Again, the point is there's a lot of things out there. In addition to what we have seen, the Medicare, Medicaid space, you also have other private commercial payers coming in space. And I always say the lines between providers, payers, health, it gets, even the larger employers are getting very blurry. I think one of the things we saw in the last couple of weeks is that JP Morgan Chase is coming up with their own health plans. Many larger employers are coming up with their own plans. So things are getting complex and blurry, but at the same time, one point is very clear, is this is the direction it's going to go. Fee for service will always be there, and one part of the conversation we'll talk about how to still need resources to maintain the profit margins of that. But at the same time, we'll show you more and more statistics of what the shift is, the member enrollment increase, and the penetration in different states are. Okay. One of the things that many of us waited on this year to see is the Biden administration's decisions impact on this specific area. Thus far, the one proposal that came out a couple of weeks ago is that overall, there's very little specific items on the Medicare, Medicaid. If you look at the numbers, it's less than 1% increase in both programs. And they actually pretty much called it the fiscal year 2022 is the bridge year. What the administration is saying that is they truly want to sit back, evaluate what's currently in place, what works, what doesn't, and come up with either new plans or modifying current models. Okay. But there is one thing to note, there is a $90 million reduction. But again, at this point, there's no new models. For the next couple of sections, one is I'm going to focus a bit on the Medicare Advantage plans. And then the second part, I'm going to focus on the Medicaid managed care programs. The reason I focus on those two is of all these plans that we talk about, well, of course, the Medicare plan is based on the HCC RAF score risk adjustment. More and more so, the state Medicaid program is taking part of that risk adjustment analogy, incorporating with their own ways of adding quality measurements, adding cost, adding different type of incentives, withholding. But to understand Medicare Advantage is important, partially is we can take a look at the percentages. It's becoming more and more larger portion of your payer mix. And secondly, if you understand this risk adjustment in this model, it helps as a foundation for other programs. So year 2020, there was a slight reduction due to COVID of enrollment in Medicare Advantage, but at the same time, 39% of total Medicare beneficiaries are currently in a Medicare Advantage program. That's 24 million people out of the 62. That's huge, right? And if you look at this diagram, that number is just going to go up and up. And the projection is that by 2030, over 50% of the Medicare population is going to be in the Medicare Advantage world. Okay. As we look at the market, there's more and more programs, Medicare Advantage plans. Payers are paying, getting into this space. we'll talk about some of the majority payers dominating the space. But currently, as of 2021, there are 3,550 Medicare Advantage plans. And average beneficiaries has access to 33 plans that they can choose from, which could be a fairly daunting task if you think about it just for patients. But at the same time, if you're a provider, that's also very complex, because now you have all these payers that could offer your traditional Medicare program, but then they also offer Medicare Advantage program. So to how to properly manage them, how to bill collect them, how to, even just from a front end patient access perspective, how to accurately document them in your patient counting system is getting more and more complex. One thing that's probably driving the increase is that more and more so Medicare Advantage programs, including drug coverage, and it's also including some of the disabilities, et cetera, coverage. Okay. As of 2020, 19 states have over 40% in enrollment in Medicare Advantage, including Colorado. Colorado is actually one of the higher ones at 43%. So if you're a provider, take a look at your payer mix, take a look at what is your Medicare payer mix, and then what is your Medicare Advantage Advantage payer mix, and then the different impact on your financial receivables. As I mentioned, the enrollment is very much concentrated among payers: United, Humana, the Blue Cross Blue Shields. They're the big boys. They just keep on growing. Every time you look around, the numbers are just getting more and more. Humana, for the first time, actually had the biggest jump in 2020. Also, more and more these private payers are outpacing public insurance in this value-based care push, right? They're introducing a lot more complex and riskier models. And one of the statistics is saying that 58% of the private payers are participating in some type of bundle payment model, compared to only 32%. 57% of the private payers are participating in the ACO model, compared to only 26% of the public payers. Again, the private payers are truly pushing, driving this move. Okay. Next, we move to the Medicaid managed care or Medicaid replacement program. Again, this is a very big overview. This is saying that this chart, you can see a lot of things are going on here, that as of 2019, 40 states have elected to do a capitated managed care model. And these risk adjustments, like I mentioned, could be a combination of a risk sharing arrangement, risk acuity type of adjustment, medical loss ratio, some type of incentive withholding arrangement that's based on cost, based on quality measures, etc. Each state does something different. And then, of course, the programs with the managed care contracts with it could be varied quite a bit. Colorado is one of the states that's actually spending less than most states in terms of Medicaid spending in this managed care model. And that's because a lot of your Medicaid populations actually being served by this PCCM model. Majority, well, you don't have any left in the fee-for-service. About 10, a little bit less than 10% in the Medicaid managed care, and then 90% in the PCCM model. Whether that shifts go one way or another, it's up to question, but it's interesting to see that how different states are shifting more and more so away from the fee-for-service. Thus far, this is another thing you can see. Thus far, that Colorado has 2 MCOs. Some of the states has a lot more. Some, like California, has 25. New York has 24. There's 12 states that don't have any. Again, just the whole gamut of things. Like we mentioned, similarly to Medicare Advantage, you see some of the big players in 10 or more states have 10 or more programs in the states. In Colorado, you have 2 plans at this point. One's United Healthcare Group, that's functioning as Rocky Mountain Health Plan, and then the other one is the Denver Health and Hospital Authority. This chart is more for understanding that the different types of measurements that's driving the incentives. Colorado, you have the pay for performance bonus, and you have the selected quality initiatives, and some of the public comparison data about MCOs. You're not currently participating in the capitation withholding program or the quality performance measure yet. But having said that, that's not saying you won't, okay? Okay, that is next slide. So based on that overview of those 2 programs, the next polling question is to say, is your organization ready to actively manage a 2-sided risk contract? Is it yes? Or is it no, you're working on it? Or is it no, it really hasn't impacted you in the way that currently is one of your priorities? We'll give it a minute. Jessica, do you have a countdown on this?
Yep, I think we're about 3 more seconds and we'll close the poll.
Okay. All right. Well, this looks great. So 10% says yes, you're ready. That's fantastic. 80% say you're working on it. That's good to know. And then another 10% says no. So again, majority of us are working on it. That's great news. And exactly how you working on it, this is kind of transition into my next portion of discussion, is talk about what are some of the ways to actively manage risk calculations. Okay. Like anything else when we talk about risk, the first question is, what is your risk tolerance, right? Historically, talking to providers, I will have providers says, yes, of course, I have Medicare managed, we cannot talk, Medicare Advantage plan, but I don't take any risks. I still have a contract as if it's a fee for service. Or I will just do upside only, or I will have two-sided risk contract, but with a capped risk percentage for both up and down. Next gen ACO is a good example that's capped at 3%. But more and more so in the marketplace, we see both a push from the provider side and the payer side to do a two-sided risk contracts without risk caps. So it's be interesting for you to review what kind of contracts you currently have and what kind of contracts you're interested in signing, and consider all the elements in terms of how is that going to impact your reimbursement. At the end of the day, the questions, of course, whomever is taking the risk, who's taking the risk, and if you know how to manage the risk, of course, then you're the one who's getting the biggest reward. So 90% of the audience here are either saying they're ready for a risk or they're working on it. One of the things that I start with is a risk readiness assessment. This is a way to evaluate your organization's ability to take on risks. There's so many different components involved. I cringe a few years back, people say, well, that's managed care thing. It's, I'm a patient in county, it doesn't really affect me, or I'm whatever, it doesn't really affect me. But the point is, this really requires a whole village to make sure things are working cohesively, because it does have a huge impact on your financials, both from opportunity standpoint, and also there's going to be pitfalls if you don't do it correctly. There's lots of resources that's required. We talked about, of course, your managed care contracting people need to be on top of things. Patient accounting, if you're going to take risks, if you have managed care advantage type of contracts, then HCC RAFs are certainly should be very important to you. Do you have certified risk coders? Do you have enough of them? Do you have coding auditors, etc.? Those are questions needs to be asked. And then, of course, on top, what is your strategic plan? This is a process. It's not something you can just jump in and run a marathon, right? You have to practice. You have to phase in risk, take some baby steps, learn from what works or what doesn't. So what is your strategic plan? And again, how to involve the different people. Do you have IT? Do you have informatics? Do you have all the data analytic capabilities to really provide you with a timely information that are actionable? Because recall, all these plans, they're essentially some type of capitation, and they're all based on the 12-month performance year to calculate, the next year reimbursement. So the window for you to do things right, frankly, is pretty short. Are the information you're receiving timely? Well, are they accurate? Are they timely? Are they actionable? Many providers do have concerns that they're getting reports from payers that could be on a quarterly basis or monthly basis. But then the question is, how old is that data, right? If you're into September, October of the year and receiving one of those reports, your hands are a little bit tied on what can you really do to improve your scores, your reimbursement for the next year. And we'll talk a bit more about the compliance exposures, as this is the area that all the governing bodies are truly starting to focus and to do audits. Okay. All these types of risk is really centered around chronic condition. The number I saw is that 80% of the care is provided to patients with chronic conditions. One of I'm going to walk through several things that as a provider, you should at least do some type of evaluation, if not already, to see where you are. One is the E&M level, whether or not there's a down code, up code, or lacking supporting documentation. Those type of scenarios all could result in either lost revenue or trigger audit adjustment. So benchmark your organization data compared to the information provided by CMS that has a specific payer setting to see if you're in line with the particular payer setting. If you're higher or lower, it's always reason to take a deeper dive into what's going on. As we say, all these risks are based on the chronic condition capturing. Accurate diagnosis and capture is critical in terms of how much you're getting reimbursed. One of the tools is that CMS provides data on 21 specific chronic conditions. They track the disease prevalence rate, utilization, and spending. And this is data that they will have by state, by specific counties. The 21 specific chronic conditions do not line up one-to-one to the HCC codes. However, majority of them do. So it should give you a very, very good indicator of how you're doing. Again, if you compare to your data and say, hey, my hospital COPD or obesity or any one of these chronic conditions seems much lower compared to this benchmark. Well, the question then, is it because you have a much healthier population? Possibly, but more likely, there's good potential to have better documentation and tracking of these conditions. Here we talk about, and I know I'm focusing on the HCC coding because this is the standard across everybody, right? That it is a starting point. Any other type of risk program could be a little bit part of this, a little bit part of that, but to have a good understanding of the CMS HCC RAP score is a particularly good starting point because majority of you as a providers are currently having a fairly large percentage of your payer mix being Medicare Advantage. So if you can properly manage this population, you will start to be able to transfer that knowledge to other programs. Why is it important? Reimbursement. So the average HCC, there's currently, I believe, 81. It changes a little bit from year to year. The average HCC, if you can capture, is about $6,000 per HCC per patient for the next year reimbursement. That money, of course, is going to be split between you as a provider, the health plan, and the administration. But again, it's $6,000. So do some sort of quick math. What is your total Medicare Advantage population? What is your membership? If you can capture one additional HCC this year, even for say 25% of the population, what does that mean for your next year reimbursement? I think we'll find that number very interesting. The other part is this HCC coding, more so OIGs coming through with the REVI audit. This REVI audit, each potential exposure, the dollar amount is rather scary. And again, because there's reimbursement involved, there's going to be audit. This is the area that they're putting a lot of focus on to make sure that there's not any type of over reporting and compliance issues. We'll talk a little bit more on the next page. right? This is something, the next few bullets are something that you can do fairly easily with your existing data. And if you have any type of data analytic type of capability, that, you know, one of the things is this thing called recapture rate. So these patients have a chronic condition, so and that's not going to change from one year to another. And typically, for a well operated operation, sorry, you should have 90% recapture rate of this at-risk population. And I'll speak from experience when we go in to do that for providers. I'm seeing the initials very often are in 30 to maybe 50%. So that's just opportunity. That's just money left on the table, right? Another one is patient outreach, the annual wellness visit. All your patients should have an annual wellness visit for the Medicare Advantage population for multiple reasons, right? One is great for their care. Two is there's no cost to the patient. And three, it's opportunity for physicians to document and capture the chronic conditions. And the reason is that, well, prior to COVID, and I think it's still going to go back to that way, is that the actual diagnose has to be face-to-face and has to be done every year. So regardless what you captured last year, starting January 1st, it has to be captured again, documented, and addressed. So you have that window from January 1st to December 31st to get all that information in order for the capitation calculation kick in next year. We talked a little bit about the coding compliance exposure. Some of the things to watch out for is history of something versus acute, history of a cancer. Well, what if the person had surgery for cancer already 3 years ago? They no longer have acute cancer, the history of cancer. Something like that would certainly trigger an audit and potential fines. Okay. Last is quality measurement. And this is also an area that Heidi would dive in a lot deeper about it. This is ACO, right? ACO, every ACO is required to establish a quality performance standard in order to be eligible for shared savings, and they're required to report this data. It's a metric to measure improvement in patient care, but it's also very often baked into different type of contract to calculate the reimbursement. So again, go through your contract to see what are you being measured on. You know, the fact is there's more and more contracts out there. It's getting complex. So it's very important to understand the different components, different measurement criteria and the reimbursement criteria for these contracts. Okay. And I'm running through this very quickly, but if you have any questions, certainly feel free to ask. Heidi, I'll turn it to you.
Thank you.
Heidi, do you want me to drive or you want to drive?
I could drive.
Okay.
Okay, I am driving. I'm the driver's seat. All right. Polling question number 3 and final. Do you know how your organization collects and shares health plan quality data to make improvements to care and services?
And Heidi, we've gotten a little bit of feedback that some people are having a hard time answering the polling question. So if that applies to you guys, go ahead and just pop your answer into that chat box there. If for some reason you can't answer that poll question. Okay, I think we've got most of our answers in. I'll go ahead and share these results with you.
Okay, so we have most of you said yes, that's wonderful. You do know how your organization collects data and reports quality improvements. So 17% said no and 17% said they were unsure. So thank you for that. So it's very important to understand that, and we're going to talk about that as we go through the rest of the slides here today. There's a lot of focus on quality when it comes to value-based care because that is how you're getting reimbursed. And so what does quality mean? I would like to bring your attention to a definition or some elements to think about when somebody says the word quality. And when you're thinking about initiatives or strategy for your organization and trying to decide what to prioritize, maybe thinking about the elements of quality and seeing how they stack up, how the options stack up against quality and using it to guide decision making. So there are 6 elements that we'll review that are used by agencies such as CMS and the National Committee for Quality Assurance, or the NCQA, to evaluate the quality of both healthcare and health plans. And so a lot of health plans are now being measured for quality outcomes. The first is the effectiveness. So how effective is your care practices or in your membership? Are you using evidence-based care, or are you continuing the practices that that were done 20 years ago and missing out on some of the better outcomes that your patients could be taking advantage of? One of the things that I've learned over the years with the implementation of electronic health records is that we did a really good job of adding work and adding work processes to our clinicians with the inventing of electronic health records. But what we don't do a great job of is finding better ways to do things, and then advising our clinical teams to stop doing some of the things that were not leading to the better outcomes. So we really need to look at those processes, and it's really leading to a lot of provider and clinician burnout. So at some point, evaluating as you discover better ways to deliver care, helping your teams adapt to those better ways by giving them the chance to adapt to those better ways and asking them and giving them the permission or the some information to let go of old practices. What about efficiency? Are we offering patients in the community access to care in an efficient way? Are we coordinating that care for them, or are we making them go to 4 different places to get the same care? For example, for an expectant mother, does she have to go to 4 or 5 different places to get her ultrasound, to get her prenatal vitamins, to get her to see a clinic provider? Because in some of our challenged areas where we don't have a lot of transportation and a lot of health equity, it's hard for patients to get to where they need to be. So we need to make it efficient for them to get the care. And that is, of course, dovetailing into our equity. And are we making sure that are we providing care based on that individual person and what they have going on in their life, and making sure that regardless of their personal characteristics, that we are providing the same care. So that whole social determinants of health is being really looked at right now to make sure that we are doing that and accounting for the patient can't get to the doctor, then that's going to be a problem. And if they're not eating healthy, then that is also going to be a problem. Some states are now requiring that we collect that social determinants of health, which is very popular in a lot of technology solutions today, and then backing that up with good practice and processes to manage that once that collection data is collected. Patient-centeredness, I cannot really emphasize this any more than to say that this is a huge part of value-based care. If we want our outcomes and our patients to be healthier, and we want patients to receive care at a reduced cost, we have to engage them. We have to find ways to meet them where we are. We have to empower them to care for themselves. And to do that requires excellent care coordination, and excellent patient education and family education so that they start to understand what it's going to take to stay out of the hospital and out of the ER and have a better lifestyle and better health. Safety, we always want to make sure that we are practicing safety with all of our patients and preventing harm. One of the things that was pretty apparent with COVID-19 and a lot of people are noticing outside of the healthcare industry is the lack of data interoperability, that we were not able to share information among caregivers when patients were staying at home and trying to receive care. So that is going to be a huge focus as we move forward into how we're leveraging technology for improvements and breaking down those communication barriers and really following patients across that care continuum. The IOM many years ago identified that breakdown in communication is one of the leading causes of patient harm. So we have got to, as a care team, come together and interact with our patients as one team. And then timeliness, are our patients able to find a provider when they need it? Are they able to make an appointment when they need it at a convenient time so that they are not waiting to receive care and then obviously ending up back in a more expensive setting like the ER or the hospital? And then we run into all those things that go with that. Not only is the patient not well and the family not well, but the organization is getting hit with readmission penalties and a lot of things that go on with that. I thought this was a very interesting slide. This is we're getting very creative in our financial incentives related to quality. There are 3 options out there right now that are pretty common in the industry, and there not only are the states offering quality-based incentive, now Medicaid managed care plans are also using quality performance metrics contract with providers. So the 3 options are listed here on the screen, and then as you see on the national map, the states, the icons in the states are which incentives are being utilized per state. Right now, Colorado is using the bonus payment based on performance against quality metrics, and that's for if the state's performance meets negotiated quality metrics, then the state pays a bonus. Some states are also using the capitation withholds, where they are the capitation withhold with payback. The state is withholding a small amount of about 1 to 2% of the Medicaid managed care plan's capitation rate. And then every year, if the performance is the quality metrics are met with what was negotiated, then that Medicaid managed care plan gets some of that back. So it's sort of a payback. And then a few states are starting to adopt this preferential auto assignment of membership. So again, quality is important in this scenario. If the enrollee is signing up for Medicaid and they did not choose a health plan, the health plans are going to be auto assigned based on their performance and their quality. So very interesting what's going on out there to leverage quality in many, many different ways for financial incentives and reduce that cost of care. So how exactly is quality measured? That might be a question that you're all asking. The National Committee for Quality Assurance, the NCQA, is a private nonprofit organization that does accredits and certifies health plans. And so there's 2 well-established health plan measurement sets that they use to do that. And one is called HEDIS and one is called CAPS. HEDIS is the Healthcare Effective Data and Information Set. And HEDIS has 191 million people are enrolled in plans that report HEDIS results. So it'd be a really good idea to, if you're not familiar with that, to go out and take a look at that. And they're looking at over 90 measures across 6 domains. And their domains are around effectiveness of care, chronic disease management, acute care, and in the wellness and preventative areas. So again, connecting with patients, good care management, it's all going to lead to better quality and meeting patients where they are and including them in their care. The CAP survey is the Consumer Assessment of Healthcare Provider and Systems. Those are standardized surveys that measure the consumer experience. A lot of elements in the CAP surveys include timeliness, access, courtesy, and administrative ease. And most of you are probably familiar with the hospital CAP score. So that's the HCAPS, hospital related, but there are also other CAP surveys that are relevant to different other settings, such as providers, which CAP survey. Health plans have now CAPS, a certain particular CAP survey. Nursing homes and dialysis all have CAP surveys that are conducive to that type of treatment center. So very, again, interesting. It's all about the quality. It's all about engaging and empowering patients to do a better job caring for these chronic conditions for the most part, which is what is impacting a lot of our country with the high cost of care. So how can we use innovation to improve quality? There's a lot of things being done in the market nationally to improve quality. Everyone is very well aware of the telehealth explosion that occurred in the last year and a half during the COVID pandemic. And telehealth was slowly being introduced, and then a lot of the things that were barriers to telehealth then became that were relaxed when the pandemic hit our country. So it used to be that you could only do a telehealth visit for a well-established patient. You could not do a telehealth visit if the patient wasn't known to you. You could only provide telehealth visits to patients within your state. Well, if you border another state and your doctor's office is in another state, then you could not do a telehealth visit. So those were some of the barriers that have now been relaxed, and we are all hoping, and this is a very, very critical time to get telehealth going in our country, because people are starting to come out of the pandemic. And if you don't have a strategy or some roadmap to leveraging telehealth to keep your patients healthy and out of the hospital, you're going to be not really taking advantage of some of the things that you could be doing with telehealth, such as providing good quality education to patients, helping them monitor their health more frequently with vital signs in the home or blood sugar machines in the home that check these things and identify times when patients aren't doing well. And those more frequent touch points are easier through telehealth, and you can intervene before it gets so bad that the patient has to go to the emergency room and have another readmission, putting your organization at risk for financial penalties. Some other innovative ways that we are improving quality is overcoming some social barriers. So giving home visits to promote access to care for children. Children are in underserved areas are not coming to the doctor, and so we're bringing the care to them so that we can promote easy access to care. And again, that care coordination can't be emphasized for people with chronic diseases, really helping to keep an eye on them. Touch points, leveraging our community health workers in the communities to help educate them and empower them to get better. The mobile produce markets, we're starting to see healthy foods being driven into the areas that need it the most, where people do not have access financially or with transportation to get to a grocery store and get healthy foods. So they go to the store on the corner, the McDonald's on the corner, and now we're starting to bring some mobile produce into mobile produce trucks into places that are needing it. Going into our communities to improve quality by job training initiatives, trying to get people on their feet and getting them some insurance or having them mentally and reducing behavioral health issues, because people are now being more productive and depression that helps combat depression. Improved access is the last innovative quality improvement example that we have, and that's just making sure that we have easy ways for people to find a provider, to get community resources, and to really look at data analytics to identify who needs the help the most and connecting them to those resources. All right, so in the last few minutes here, I will I will go over what our takeaways are for this group as finance leaders or leaders in general. And I think we pretty much emphasized throughout the presentation that better care for individuals plus better health for populations equals a lower cost of care for everyone. And so focusing on that community, the health of communities and populations are really at the core of value-based contracting and value-based care, and really tying that reimbursement to quality and outcomes. And to do that is going to require different care models and thinking outside the box to really engage patients in their care, going into more innovative ways to take care to the patient in a way that they can absorb and understand. And quality is definitely being measured by both health plans and providers. So make sure that your organization understands your contracts. If the teams, and that's just not the providers, but the care teams as well, don't know how they're being measured, it's challenging for them to prioritize what they should be doing to get the best outcomes and make the most impactful improvements. And then make sure your technology is configured for success. Look at your interoperability between your systems. Are you able to provide a seamless transition from one touch point to the other across that continuum, and share the information that was given at the previous setting with the next setting, so that we have seamless transitions of care and patients aren't starting over every time they have a touch point with the provider in your healthcare system. And I keep looking at my clock. I think it's almost time for us to wrap it up, but I wanted to stop sharing and see if there's any questions. You can put them in the Q&A if so.
Yeah, there's our contact information's at the back, of course, if you have any questions specifically. There's also a slide, just gave you some reference in terms of how COVID has impacted both Medicare Advantage and Medicaid. There's a lot more to come, of course, in that area.
Yes, thank you. Thank you so much, Dr. Steiner and Ms. Marr, for the incredible information and sharing your time and your expertise with us today. For those of you who are going to have to jump off right at that 1 o'clock time, I do just want to remind you that the presentation is downloadable. There is a link to it on our website, www.hfma-co.org. There is also a link that I populated in that chat box. So scroll up and access that before you have to go. We do have a couple questions. So for those of you who have a few minutes, if you have questions, pop it into that chat box. And otherwise, I did just want to ask some of these that came in. Should a financial impact analysis be part of the risk readiness assessment?
I can, sure. I'm the finance person. I can certainly address it. Absolutely. I mean, unequivocally, and not just straightforward to say, okay, what is this contract mean in terms of reimbursement? In terms of, is this shifting my current Medicare population into Medicare Advantage, or am I getting additional members, right? That's one consideration. What does it mean in terms of my actual reimbursement? Things such as historical patient leakage, etc. Those becomes increasingly important, because you're liable to pay your neighboring hospital if the patient went over there that's not within your network, out of your pocket. And then in addition, some of the things to consider is from a cost report standpoint, now your Medicare bad debt could be lower, because that's that population could be shrinking. So there's lots of components to think about. And also just when you're signing those contracts, whatever contract you're signing, really truly consider all the ramifications. What happens, I always say, what happens if a patient does not pay their co-insurance deductible? You know, in the Medicare Advantage world, there's of course less patient responsibility, but there is still that question. Could you build that into your contract, etc. So all those things or certainly impact your financial bottom line. And of course, you know, from a resource standpoint, what additional resources you need? Is your in-house staff, in-house technology sufficient? So all those, again, it's not an easy answer, but certainly.
Thank you. And I do want to be respectful of our speakers' times as well. Do you guys have time for one more question?
Sure.
All right, we do have one additional in here, and then we'll let you guys go too. Quick reminder again, contact information is in that presentation. So if you guys have questions, I know they would be more than happy to answer those for you offline. So our last question here is, where collateral is required in two-sided risk programs, how are most of the entities you advise funding this collateral? With internal cash resources, surety, bonds, etc.? Question mark.
Again, I see variations in that. I'm not the expert. I just see what people do. It is a variation of that, what you just mentioned. But yes, we certainly have other people in the firm who specialize that particular area that they can give you more guided answer.
That'll work. Well, thank you again. We really appreciate you giving your time to us today. And to everyone else, thank you so much for coming and sharing your lunchtime with us. And we hope to see you at a future HFMA Colorado webinar. Thank you all very much.
Thank you.
Thank you. Have a great day.
You too.